and burden and a rapidly expanding at-risk population. These statistics, by the way, are from CDC. Notably, type 2 diabetes accounts for nearly 90 to 95% of all the diagnosed cases and is strongly associated with modifiable risk factors such as physical inactivity, obesity, and unhealthy nutrition. With adult obesity rates exceeding 40%, the urgency for prevention has intensified. The economic burden is equally substantial, with diabetes costing an estimated $640 billion annually, accounting for nearly one quarter of total US healthcare expenditure, underscoring its far-reaching fiscal and systemic impact. Despite this, diabetes remains a largely preventable condition. Evidence from the Diabetes Prevention Program demonstrates that structured lifestyle interventions, including increased physical activity, improved nutrition, peer support, and stress reduction practices such as yoga, can reduce the incidence of type 2 diabetes by up to 58%. However, the adoption and scalability of such interventions remain uneven, constrained by gaps in reimbursement mechanisms, limited provider referrals, and insufficient integration with community-based wellness ecosystems. This highlights the critical need for policy-driven, community-centered approaches that bridge clinical care with preventive, lifestyle-based solutions. This policy cafe this evening brings together cross-sector experts to explore how federal initiatives and community-based models can work together to strengthen prevention, expand access to lifestyle interventions, and reduce the long-term burden of type 2 diabetes. As part of this conversation, we'll be exploring two core themes. The first one is focused around federal policy and financing for type 2 diabetes in prevention. Second core theme is anchored around community wellness and lifestyle change. We got a fantastic panel of experts. So what I like to do is, first of all, go through some introductions right now. It's my privilege to introduce our esteemed panelists who will guide us through a very thoughtful and enriching exploration of today's conversation. First and foremost, I would like to welcome Dr. Ambika Ashraf. Dr. Ambika Ashraf is Professor of Pediatrics and Division Director of Pediatric Endocrinology at the University of Alabama at Birmingham and Associate Director of the Comprehensive Diabetes Center. She is a nationally recognized expert in pediatric obesity, type 2 diabetes, and metabolic health. Her research focuses on insulin resistance, fatty liver disease, lipid disorders, and disparities in pediatric diabetes, and she serves as a co-principal investigator in an NIH-funded multi-center study on youth-onset type 2 diabetes. Dr. Ashraf is actively involved in national organizations, including the Pediatric Endocrine Society and the Endocrine Society. Her work is centered on improving early prevention, advancing equitable care, and addressing the growing burden of diabetes in children and adolescents. Thank you, Ambika ji, for joining today. Next, we have Dr. Ulupi Chokshi. Dr. Ulupi Chokshi is an experienced endocrinologist with over 48 years of practice, specializing in diabetes and metabolic disorders. She focuses on managing complex hormonal.
Madhavji, you're on mute currently.
Okay. I'm not sure when I went on mute, hopefully just now. Okay. We have with us Dr. Ulupi Chokshi. Dr. Ulupi Chokshi is an experienced endocrinologist with over 48 years of practice, specializing in diabetes and metabolic disorders. She focuses on managing complex hormonal conditions and improving blood sugar control. Dr. Chokshi earned her medical degree from Seth Medical College, University of Mumbai, and completed her training in internal medicine and endocrinology at Cook County Hospital and MD Anderson Cancer Center. Board certified in internal medicine, she currently practices at Baylor St. Luke's Medical Group in the Woodlands, Texas. Next, I would like to invite Dr. Jyoti Gundavarapu, Internal Medicine Education and Training Specialist. Dr. Jyotirmai Gundavarapu is an internist in Marietta, Georgia. She received her medical degree from Gandhi Medical College and has been in practice for more than 20 years. She has expertise in treating coronary artery disease, diabetes, hypertension, and high blood pressure, among other conditions. Thank you, Dr. Jyoti. Next, we have Dr. Alka Kanaya, Professor, Medicine, University of California, San Francisco. A clinician researcher specializing in type 2 diabetes and obesity, her work spans three integrated areas: identifying novel biomarkers linked to metabolic risk, building a population-based South Asian cohort called Masala to study diabetes and cardiovascular disease, and testing behavioral interventions for prevention. Her research has demonstrated strong links between visceral adiposity, adipocytokinase, and disease risk. She has led multiple NIH and AHA funded studies, including randomized controlled trials in lifestyle interventions and restorative yoga, with a focus on high risk and underserved populations, aiming to better understand risk factors and develop effective, culturally informed prevention strategies. Next, we have with us Vidya Nahar, Chair Yoga and Icon Shakti founder, director, Vyayam of Chicago. Vidya Nahar has over 45 years of yoga practice and has been teaching since 2004 in Chicago through vyayam.com. She conducts 100 plus monthly classes, leads workshops across community spaces, offers a Yoga Alliance certified 200-hour training, and is an active community organizer. In addition to serving on the advisory board of Sewa's Chicago chapter, she supports many organizations such as Chinmaya Mission, Jain Center of Chicago, Maharashtra Mandal, Lake County Indians Association, Lake County Ganesh Mandal, etc. Next, and last but not the least, I would like to welcome Dr. Venkat Narayan, Executive Director, Emory University's Global Diabetes Research Center. Dr. Venkat Narayan is Executive Director of Emory Global Diabetic Research Center and Ruth and O.C. Hubert Professor of Global Health and Epidemiology at Emory University. A globally recognized diabetes expert, he is a member of the US National Academy of Medicine and a foreign fellow of the Indian National Science Academy. He received the American Diabetes Association's Kelly West Award for Excellence in Epidemiology. His multidisciplinary work spans diabetes and non-communicable diseases, focusing on epidemiology, pathophysiology, translation research, and public health. Wow, we got an esteemed panel, as you can see. Now, with no further delay, what I like to do is to dive into today's conversation. Let's start with Dr. Ulupi Chokshi. Dr. Ulupi, from your experience as an endocrinologist, what are the most common early metabolic patterns or warning signs you see when it comes to type 2 diabetes before it fully develops?
Well, to some extent, type 2 diabetes is a silent disease. So nowadays, what we see is incidental discovery when someone gets an annual physical exam or lab work performed, even when they are quite asymptomatic or not have any symptoms related to their type 2 diabetes. And that holds true again, even in younger individuals as well. I see that we have some really good panel members here who will definitely tell us more about it. The other way is a surprise, especially when it comes to type 1 diabetes, when someone presents with marked symptoms of losing weight unexpectedly and feeling unwell with going to the bathroom a lot, and classic symptoms of extremely elevated blood sugars, which usually indicate in a younger thin person type 1 diabetes. But our battle with stop diabetes movement at this time is essentially with type 2 diabetes, though we have made tremendous progress in identifying and improving lives of type 1 diabetes as well. And we have made significant progress in terms of islet cell transplants and other immune modifying therapies and early diagnosis, especially in siblings who are more vulnerable, type of thing. So it's usually through an annual exam or routine blood work. Then most of the times the primary care physician will notice that the blood sugars are not normal, and then it will be further investigated. And that's the window of opportunity that we should all be looking for, making the biggest impact, and especially in my not quite 48 years, but in my about 35 years of practice, I have seen diabetes clinical management change and evolve dramatically. We do not have to do the finger stick blood sugars, and we have a very good idea with continuous glucose monitoring systems that we use, so that it helps even at the level of pre-diabetes to make the appropriate daily habit changes that we need to make. So just wearing it for diagnostic purposes in case of pre-diabetes, that we, as you explained earlier, we have 115 million or so in USA. And USA is one of the countries where we are able to make earlier diagnosis just because of our healthcare screening system and annual physical exams, etc. But all over the world in just 2026, we have seen extreme situations in Asia, Asian countries, as well as certain parts of South America and certain other countries like Africa and places like that, where there is so much undiagnosed diabetes and pre-diabetes. So when we look at the bigger worldwide picture, we have definitely a bigger task on our hands, so to speak. So, including in India, there is still a significant amount of diabetes and pre-diabetes that is not recognized and that is not attended to, even though some of our wonderful yoga programs and dietary modifications and lifestyle changes originated in our country. So I think there is a lot of work to be done, not only in USA, but all over the world. So to summarize, I think that pre-diabetes and diabetes can be totally asymptomatic, but it's very important to recognize early so that we can do the best we can do.
Yeah. Those are some wonderful insights. By the way, apologies for making you 13 years older than you are. But but I think you touch on a very important point, which is this undiagnosed conditions, right? So the symptoms sometimes show up a little too late. So maybe going to Dr. Jyoti Gundavarapu, of course, you see a lot of patients as part of your clinical practice.
Yes.
So, what are some of the risk factors when it comes to, say, lifestyle behaviors or, factors that could accelerate diabetes onset?
Yeah, so yeah, that definitely, yeah. So there a lot of people think like, oh, they only get diabetes if they eat sugar or sweets, that kind of thing. But there are a lot of things, like people can change before they become pre-diabetic or diabetic, like get a head start on their conditions. So I'm gonna just kind of give like a highlights on the important ones. The most important, most neglected one is sleep, poor sleep. A lot of people, I mean, most of us, I think, don't get enough sleep. I think that's common in America, India, everywhere. So what happens if you don't get enough sleep? Your cortisol goes up, your hormones grow up, and, your sugar goes up. And then, people, that hunger hormone levels are high. Then you crave food, then you eat carbs, and it becomes a vicious cycle, right? So important 7 to 8 hours of sleep at least every day, which is a simple, I mean, it's not, a lot of people don't even think it's related to diabetic. So, and another one is the sedentary lifestyle. Most of us lead, getting in and out of cars, just, sitting around. What happens when you just sit? Your glucose is not metabolized, right? You're not burning your sugars. And like you eat lunch, you eat dinner, you just kind of sit around, watch TV. So, like even like simple things like get up and walk 10 minutes after dinner, like 10 minutes after lunch, your sugar will go down. So this, even normal people can do that. You don't have to be diabetic or pre-diabetics, these are like healthy lifestyles everybody should follow to prevent diabetes. And then, of course, late dinners, eating late definitely increases your sugar. Then again, your body's producing more insulin to digest all that sugar. So, and then I know a lot of people are into these smoothie cravings, smoothie craze now. Everybody makes smoothies of everything. I put a bunch of a whole bunch of fruit, whole bunch of this, that, sugar, milk, cream, and then these are all calories that just you're consuming a lot of, and, probably hidden sugars. I think that was another thing I thought, all these. And then stress. The most important thing is chronic stress. I think stress has become a big problem everywhere, right? Like everybody has stress levels. Every time your body is under stress, you produce this stress hormone called cortisol. So, that is a defense mechanism. But if you're under stress all the time, that means your cortisol is high all the time. Whenever your cortisol is high, then it acts on your sugar cells, right? It starts increasing your sugar levels. So that is one other neglected thing is stress. Sleep, stress, very important. Of course, ultra processed foods. I think all of us are in that world of ultra processed food now. Everything grab and go, quick eating, grab, all these deceiving marketing like low sugar product, this product, that product we buy, packaged foods, very deceiving. They might have a lot of sugar in them. So I think these are all the things you can start doing. This is things that you can do to prevent yourself, before you become diabetic or pre-diabetic. Another thing you asked earlier about some of the signs some people can recognize. I know mostly it's asymptomatic, but I'm just one point I've noticed, like say if you start getting like skin tags and dark discoloration around your neck or back. It's called acanthosis nigrans, and you're getting excessive skin tags. So that could be a sign of insulin resistance. So, you have to kind of, it's not like the diagnostic, but if anybody's looking for it, that's one of the signs you can look for, before you start getting increased thirst, increased hunger type things. And if there is a strong family history, I think people should get their A1C checked with every physical. I don't know if fasting insulin is a good idea. Maybe the diabetic experts can tell us about it. Sometimes I'm also doing that, fasting insulin levels. Sometimes maybe one of the experts can comment on that later, So these are the main things at this point for lifestyle, activity, good sleep, reduce the stress. These are what I would recommend, Yeah.
It's quite interesting and quite fascinating, some of the things that you're talking about, especially sleep. For the better part of my career, I wore it almost like a badge of honor to say sleep is overrated. I slept for 4 hours last night and I'm ready to go, right? So I think uh, I think sometimes these lifestyle practices compound over a period of time, right? And suddenly you will require more like a clinical intervention. So I think it's very interesting, some of the insights you're bringing to the conversation. What I like to do now is, Dr. Ambika, I'll switch the conversation to you because, as Dr. Gundavarpu spoke about, she's obviously looking at more of adult population, I'm assuming. And you look at patient population at a very early age. So Maybe if you can share a little bit about what are some early life determinants, right? Even lifestyle could be a factor there, environmental factors, what is shaping diabetes risk to be elevated now? And do we trace it to our childhood practices?
That's a really important question. So let me share. When I started my journey as a pediatric endocrinologist 25 years ago, so if we have child with new onset diagnosis of diabetes, we never thought about type 2 diabetes. Fast
Okay.
forward 25 years now, all the new onset diabetes we get, 50%, almost half of them have type 2 diabetes. So the trajectory has changed. So this makes us think about what has changed. So two things I would say. One is biology, one is environment. So biology, when I talk about biology, that is like first 1,000 days of life. It doesn't start after birth, it's in the womb. So we are metabolically programmed in the womb of the mother. So if the child is exposed to gestational diabetes, that is mother has diabetes. If mom has excessive weight gain during pregnancy, if the maternal blood sugars are not very well controlled, all of this is going to lay blueprints or like program, the first programming of the body. The risk is tilted towards higher risk of developing diabetes. So our programming is already started. So now also if the baby is born with low birth weight, that also increases the risk of future diabetes. And then that biology meets the environment when the baby is born. So our environment, as already Jyotiji has mentioned about, environment is sedentary, we have less activity, we are exposed to more processed food, sugary drinks, everything together. Chronic stress, even for children, they are living in homes with chronic stress, poor sleep. So all of this predispose a child, that compounds the risk, that really amplifies the risk of developing type 2 diabetes. So what we are dealing with is like, we have double risk. Now we are predisposed. And then on top of it, just to add upon what is already being said, if you have family history, for example, if one parent has type 2 diabetes, the risk is around 20 to 30% higher for the offspring to get type 2 diabetes. If both parents are affected with type 2 diabetes, you have almost 60 or above 60% or more risk. If you have one sibling also, the risk is much higher. So the hard part is there is a little bit of genetics, there's a little bit of biology, and then that is also adversely influenced by our environment. And lots of which is like, what we call epigenetic changes. So when we are in the mother's womb, our DNA undergoes, not the DNA itself, but it undergoes some changes called methylation. And that happens in response to nutrition, toxic environment, inflammation, all of the stress. So all of this shape us. So in some ways, we have to start very early prevention, starting from adolescents or teenagers who are going to become mothers. So prevention has to start very early. Thank you.
It's quite interesting because sometimes there is this mistaken notion that he's a child or she's a child and their metabolism is high. You can digest anything, right? So what you're saying is some of these lifestyle practices have to start. It's literally a lifetime of practice, right? It takes not just I'll deal with problems when I run into them. So quite interesting. Thanks for those insights. And now, what I like to do is maybe switch the topics a little bit to macro, to the bigger picture, right? If we think about our communities. So, Dr. Narayan, I know you're an expert crisscrossing the policy and the clinical interventions and so on and so forth. So, what I like to ask you is, what is one scalable intervention or a model that you believe has the highest potential to make a positive impact on diabetes within communities?
Yeah, thank you, Madhav. So before I answer that, there's a couple of ideas that came up that I would like to quickly clarify. Firstly, Jyoti mentioned doing a hemoglobin A1C and the value of a fasting insulin. What I would suggest is what will be more useful is a hemoglobin A1C and a fasting glucose, because I think that will be particularly in the Indian context. A fasting insulin for clinical uses probably is not really valuable. That's one thing. And Ambika's perspective is extremely correct. In fact, there have been studies showing that a mother's weight gain, a mother who's during pregnancy is obese or has excess weight gain, and the mother's glucose during pregnancy, those two factors increase the risk of a child's diabetes very young by about 50%. So
Wow.
essentially, you got to start in the womb, literally. So it's the mother's health that is going to be important. I think that is where prevention at least needs to start. And secondly, we've also done studies showing that by age 5 in a child, most of the factors that lead to obesity get set. Beyond that, the horse has left the barn, and it's difficult to reverse it. So I think that's one important message to take home, is that whatever you do, pay attention to mother's health, mother's glucose, mother's weight gain, mother's obesity, and then the first 5 years of the formative 5 years of life is extremely important. Now, coming to your main question, Madhav, you mentioned the diabetes prevention program, which it's a classic in the field. It's a $160 million NIH study, 27 centers. I happen to know the study very well because I was involved in its origins. When I was at the NIH, my mentor, Bill Noller, was designing it, and we wrote the design paper together. So this study was a simple study. We took people who were obese. I mean, in the US, it is overweight, but in the US, everybody who got enrolled had a BMI of 30 and over. They had a pre-diabetic condition called impaired glucose tolerance, where your 2-hour glucose is high on a glucose tolerance test, but your fasting glucoses are normal. So it's not high enough to be diabetes, but it's higher than normal. So obese people with what's called IGT, and they were randomized to 4 groups. The 4th group fell off. We won't get into it. But the 3 major groups, roughly 1,000 people in each group. The first group received a placebo, and just the kind of guidance you'd say in a clinic, go lose your weight, change your diet, etc. The second group received what we called an intensive lifestyle program, which is what has evolved, which is called the DPP lifestyle program. It is 16 weeks of intervention. In the study, it was delivered one-on-one, but since then it's been adapted to group interventions. And then 8 weeks of maintenance. So changing behavior, it was felt, takes 24 weeks in that study, according to that study. And that study was designed by behavioralists, by nutritionists, by exercise physiologists, etc. So that was the second group. The third group was put on a drug called metformin, which is used to control glucose. But in that study, it was tested to prevent diabetes. And the results of the study were published about a quarter of a century ago. Okay, and those results, having been involved in that study, were probably the most exciting results that I have ever witnessed. Sitting in the room where the results were revealed was one of the most dramatic moments in my life. 100 of us sitting in a room where confidentially they released the results before it got published in the New England Journal of Medicine, and we get to review the manuscript and edit it, etc. It was dramatic. What it showed was the lifestyle intervention reduced the progression to diabetes from pre-diabetes by 58%. It was twice as effective as metformin, the drug.
Wow.
Okay? So it was a very powerful intervention. And if this was a drug, I can bet you 70 to 80% of the population of the country would have been on it by now. But it's not the case. It wasn't a drug. And when it's not a drug, it's an orphan intervention. There's not many takers for it. So, and over the last 25 years, you asked what is potentially scalable. I think this intervention is potentially scalable, but it has to be a societal response. The problem is threefold. Number one, there is no buyers for it. I mean, there is very little, commodification or commercial interest, unfortunately. Whether it can be generated, I don't know. Second, through a lot of, advocacy, etc., several organizations like commercial plans, Medicaid, Medicare, the VA, are all providing it, but providing it in a very haphazard manner. Its implementation is very haphazard, and it's also target driven. It's almost like if you lost 5% of your weight, then we will continue to reimburse your sessions. We don't say that. You don't tell your patients, if your glucose doesn't control, we won't reimburse your drug. You don't say that, but here we do that. Okay, this is what the government does for whatever reason. So this is somewhere policy intervention is required. And the third really is, somebody mentioned 115 million people with pre-diabetes in the country who would all be eligible for this intervention, but so far only about 1 million in the last 25 years have taken on the intervention, have got enrolled in this program. It's why. The question, I think, as citizens, we need to ask the question, why? But one thing is, among the people who take on the program, a very high proportion finish it and on average lose about 5% of weight loss and change their behaviors, and about 80% of them report benefits. So that is one scalable intervention. And the intervention is simple. Physical activity, 30 to 45 minutes a day, even if you walked, brisk walking is enough. If you're overweight, lose between 5 to 7% of your body weight, and change your diet to healthier diets, like lower refined carbohydrates, increase the high fiber carbohydrates, increase fiber in your diet, increase fruits and vegetables in your diet, and in the context of Indians, increase protein in your diet, very important, healthy protein in your diet. Reduce the amount of fried food, shift towards more healthier oils if you can. And definitely, like what Jyoti said, sleep is important. I mean, we didn't study it at that time, but now I would say it's a very important intervention. 7 to 8 hours, not just quantity of sleep, but quality of sleep. Don't watch television before you go to bed. Don't eat before you go to bed. Draw the curtains, make your room as dark as possible. Lie down, go die and wake up in the morning fully alive. That should be the formula. And in many ways, when you think about it, I keep saying the DPP intervention is what our ancestors did, the monkeys did. They ate in small quantities, they ate fruits and vegetables, not refined carbohydrates, not processed foods. They ate a lot of nuts, fruits, vegetables. They jumped around and played around. And they slept when it was dark. They were awake when it was light. I think that's evolutionarily, that's the kind of diet we need. And I think so, can we scale it up? That's one question. The second is a more complex question. What we've understood, doing this kind of intervention in a structured way works. But like I said, there are many barriers to its implementation at the societal level, at the individual level too. Because the availability of all the things that fight against it are too pervasive. I mean, the diets that are served are high refined carbohydrates, processed foods, things that make you eat a lot. You go to a wedding, there's 160 items in the buffet. So there is, every time it's about eating, physical activity is never promoted. So those are some of the barriers. But the other barrier, which we should understand, thanks to this new drug called the GLP-1 agonists, they have revealed that obesity is not just a behavioral disease, it's a biological disease. Many of the factors that make us behave that way are biological. So we need to understand the biology. And one of the good things is people that are going on to the drug appear to be opting for a more healthier lifestyle, whether it's higher physical activity, higher weight training, higher, healthier foods. So maybe we should understand the biology of behavior change to promote behavior change also. So I would say two things: policy level interventions to make these interventions available to people, promote a societal culture starting all the way from pregnancy and beyond, and make it like a group activity, but also understand the biology of behavior a lot better. I think probably so. That in a long-winded way, those are the kind of things we should be thinking about.
Very, yeah, very practical because you're touching on two aspects, right? At a micro level, at an individual level, what kind of interventions that we can practice, each one of us. But at a macro policy level, it's quite fascinating. In fact, the thing about sleep that you talked about and Jyoti talked about as well triggered something in my mind. Um, I was reading somewhere that 7 hours of sleep plus 1 hour of exercise versus 8 hours of sleep. Maybe 8 hours of sleep should take precedence. I don't know. These are all rules of thumb, right? But you know, yeah. Go ahead. You're saying something, Venkat.
No, I agree. No, sure.
Yeah.
So I think seven
Yeah.
to 8 hours of sleep. Too much sleep is also bad, but anyway, yeah, but that's a different
Sure.
matter.
Sure. I think the quote was something like 6 hours of sleep plus 1 hour of exercise versus 7 hours of sleep, right? Something like that. But it's quite
I
interesting.
think you still need
Oh,
to exercise though.
of
Even
course.
though you can't skip exercise because of sleeping.
Yeah. In fact, the GLP-1 topic you brought up is also very interesting because I work with a lot of food manufacturers. And one of the things that we are seeing is they're already GLP-1s are having such an impact that they're reducing the portion sizes catered towards the GLP-1 population, as well as there is also this effect where GLP-1 moms is something I hear about, where the mother starts taking GLP-1. Apparently, the family lifestyle also changes.
Change.
So some interesting side effects. And the other thing I saw was with the GLP-1 usage, there is an uptick in the apparel industry because now people want to change their wardrobe, go to the gym memberships are going up, so on and so forth. So I think it's a fantastic intervention, even from a medical perspective. Yes,
It's all, and
Dr. Chokshi.
it's also promoting physicians to pay
That's
attention to
good.
obesity now. Things that they were
Yeah.
never interested in, they're suddenly being interested in.
Yeah. Yes, Dr. Chokshi, you're saying something.
So, couple of comments. I think we all address the basic, and I totally agree that I think it's the level of pre-pregnancy diabetes control and habits that we need to pay attention to. And as far as the lifestyle is concerned, one other factor that has been brought into limelight is social connections. When people are lonely and people are stressed, and a lot of individuals nowadays, I mean, probably not so many Indians, but live alone when they're 18 years old and onwards. And then there are a lot of single older individuals as well. And if they don't have that social connection, so there are, of course, diet, activity, hydration is extremely important too, because sometimes people are drinking soda and or alcohol usage and things like that when they are lonely or isolated,
Mm.
and stress factors into too, because all the stress related hormones are anti-insulin, so they will
Mm.
definitely make insulin resistance worse. And to support the fact that the newer agents, the SGLT2 agents, as well as the GLP-1 RAs, and there are several in the pipeline, as I'm sure all the participants know, that actually calm down the noise in the hypothalamus area about cravings and eating when you are not hungry. Just because you are at home and you have access to ice cream or whatever temptations you have around you when you are not necessarily hungry. So those
Mm.
factors, lifestyle changes, are extremely basic and important. And once we get these in control, along with the right medications as clinicians, what happens is we do see remission or reversal, but we don't call it that you are cured of diabetes. We say your
Yeah,
diabetes is in remission right now. Because,
totally.
and I have had a chance to take off a lot of patients off of insulin when they have lost 50, 60, 70 pounds whereas before their A1Cs were 12 and 13, and now they are at 5.7 and 5.8. So that happens. That's
Fascinating.
wonderful progress that we have seen in type 2 diabetes for sure. And now,
Fascinating.
of course, the GLP-1 agents are also getting indications for people with type 1 diabetes because of the beneficial other effects that we see.
Wonderful. I know, Dr. Ashraf, I see your hand up. I know we need to get to Dr. Kanaya and Nahara's Vidyaji as well. So, yeah, if you can make a quick comment and then, yeah.
To add upon to what was already said, in pediatrics also we see the same beneficial effects of GLP-1 medication. So when we see children with type 2 diabetes, they have a really adverse course. Prior to GLP-1, most of them will become insulin dependent by within 5 years of diagnosis, and then within 10 to 12 years, they will develop complications like kidney damage, eye problem, nerve damage. But now with the GLP medications, what we are seeing is they're losing weight 10 to 15% of their body weight, and their diabetes go away. They're out of their insulin, blood pressure medications we can control, liver fat is reduced. So many beneficial effects. And to add upon to that, what you were talking about, the stress, what we see in children, just to think about, like when parents are working, when they're alone, they just eat out of boredom also, and that's also like one of the challenges of modern world. And also when you are really stressed, when you have chronic stress in the family, we are going for comfort foods. Nobody reaches out for broccoli or something when you're stressed. You just want ice cream or some chips, or, just the impact of stress. I just wanted to emphasize. Thank you.
Oh, thanks for sharing those insights as well. So those factors translate into children as well, whether it is GLP-1s, stress-related factors, and so on. So wonderful insight. Now, what I like to do is switch the topic to, again, the macro, right? The populations that are vulnerable. So, Dr. Kanaya, you're an epidemiologist, right? So applying that lens, what populations or communities or demographics, however you want to think about it, are most vulnerable to diabetes today?
Yeah, that's a very good question. And happily, we have some data from the United States now, the most multicultural, country in the world. We have national data as well as data from health systems like Kaiser and Sutter. And these data look at not only prevalence, like who has diabetes now, but incidence of diabetes, who develops diabetes over a few years of time. And what the data shows very clearly is there are certain groups that are much higher, both in prevalence and incidence of diabetes across the US. And the highest ranked group is actually Native Hawaiian and Pacific Islanders, definitely higher than almost any other group. The next is South Asians. If you aggregate all South Asians together, that's Indian, Pakistani, Bangladeshi being the three largest subgroups of South Asians that have been included in these studies. The third is Filipino. And then I'll put Native American kind of in that mix around the level of Filipino. The next is Latino populations. And just like South Asians, Latino is a very broad, heterogeneous group. And so if you break it down, and there's some nice epidemiologic studies that have enrolled lots of Puerto Ricans, Cubans, Mexicans, and South Americans, and there's clearly differences among these groups, with Puerto Ricans being highest, followed by Mexicans, then Cubans, and then South Americans. Next is Black Americans. And then we get the other Southeast Asians like Vietnamese, and then East Asians like Chinese, Japanese, and Korean. And last is white European. So I just kind of gave you a rank order in terms of the highest to the lowest. And I know that's a lot of data, but that's a very clear kind of pattern that we've seen in multiple different studies that have been done over the last decade.
Very, very interesting. In fact, through my engagement with Venkat's team as well, with Emory, I picked up this phrase called phenotypes. I'm no medical expert, but it's a very interesting lens to apply. I think this can also translate into community interventions, saying if you belong to a higher risk group, you need to be a little bit more thoughtful in terms of, what kind of lifestyle that you would adapt.
Exactly.
Uh, it's quite interesting. I think what we are doing is connecting this macro picture and micro picture at an individual level. So thanks for bringing those perspectives. Vidyaji, we talked enough about lifestyle interventions, and you're a yoga expert. So tell us more about, uh, how people's lifestyle habits and how they impact diabetes risk, right? Yoga, of course, as a practice, from everything I hear, I try, but everything I hear, it's a wonderful intervention. So would love to get your perspective on that.
Yes, so I'm all in the lifestyle intervention field now because all of you are, mostly physicians who are dealing with patients who have actually now progressed in their diabetes, and now they are coming to you for getting the cure. And I'm in the field of preventing it from, getting into it in your body in the very first place. So I have seen over the time the change in the perspective of people. So earlier when I started teaching about 20 years back, and I've been practicing on my own yoga for more than 50 years now. And I also teach healthy vegetarian cooking. So just by vegetarian cooking, sometimes people say, "Oh, I'm vegetarian," but all if you're eating pizza, pasta, cookies, pretzels, potatoes, then that's not going to do any good. So eating healthy vegetarian is important. By that I mean whole grains and fruits, vegetables. So using those cooking and incorporating that in our day-to-day eating, not just some weekend meal like that. So this I started teaching 20 years back because I learned about it when I started cooking here. I read wonderful books by Dr. Malti Karwarkar. She was an Indian nutritionist, so she was much ahead of her time. She had written these books about I read those in 1980s. So you can imagine, and she had traveled around the world, and that time she had mentioned avoid these 5 white things: white sugar, white bread, white rice, white flour from your diet. So this was all talked about even then. It's not nothing new. So if you're thinking these are new situations, new phenomena, no, it has been there. And I was lucky enough to read those books before I came here. So when I started cooking here for my family, I changed my lifestyle completely and incorporated eating healthy whole grains, whole proteins in my diet. So when I used to talk about those things with my friends, that time they would not understand the importance of it, or they'll just like brush it over. Oh, here comes another healthy eating person. Or when I was to talk about yoga, but now there is much more acceptance of all these things that I've been talking all then. Now people are more open to learning about this lifestyle intervention issues, and they know that this actually works. I have been able to keep these things at bay for myself, at least for my family, that I'm not on any medication, not taking anything, by using eating whole grains, vegetable based, like healthy proteins, healthy fats, and of course practicing yoga. So I'm seeing now there's a lot more awareness in the general population. While there is also increase in the disease, but there's also more acceptance of lifestyle intervention ideas. People are more open to that, and there's a lot more information is also available because of YouTube videos and of course WhatsApp forwards. People get to read a lot more about these issues, so they are again more open to making those changes in their lifestyles. So I'm seeing it more
Wonderful.
positive.
Yeah. I think I even hear about programs like food as medicine, right? So food in itself has got a
And even the
healing
movement is
and
medicine, right? So movement and food, they both are medicine. So
yeah, totally. Totally. I think integrating diet, exercise, lifestyle, all these can help us kick the can down the road, even if we are at a higher risk for diabetes. Um, Thanks for sharing those thoughts. Maybe what we will do is for the next round, maybe we'll start getting into a little bit more of a rapid fire kind of mode. So, Dr. Chokshi, you already gave some insights, right? About some clinical insights about diabetes prevention. The more people should know, but often don't. So, anything you want to add? Maybe one clinical intervention that most people, it would be like an aha when they hear.
So nowadays, we do unfortunately see diabetes sometimes too late as the first when they have kidney failure or they have diabetic retinopathy or they have a cardiovascular disease. Instead, like, earlier it was discussed, if we know that this child or this family has very high likelihood that this one is going to be vulnerable, this individual, then we should really, really start paying attention to these habits earlier. I think the diet is extremely important. And so I always, in my clinical practice, when I see, and get so many times referral because I've seen the mother, I will get the mother's sister and the mother's daughter, and then the husband comes to see me. So I think if we can really think about woman as the person who is in charge of the kitchen and the groceries and the way things get served, and you don't want to give child a Ziploc bag full of Fruit Loops just to keep him quiet or something like that. But if we have those habits corrected at the level of who's in charge of the, like, earlier it was mentioned that cooking is very important, but at the same time we live in a very fast paced world. The mother and father both are working, they don't have time to cook home cooked meals, and the children get either an iPad or a device to keep them busy, and then if they are still like the pediatric endocrinologist mentioned, 5 years old, but even 3 and 4 years old are playing on their iPads and eating things out of Ziploc bag because the mother is too busy or they are at the daycare center. So I think increasing the awareness, what we are doing, making sure that the family takes time to do activities together, including going out to the park for a walk and let the child play, exposing to fresh air and physical activity is extremely important. So these are the things that we can do at the grassroots level, where I think, to me, the person who is in charge of grocery shopping, because if you don't have it in your pantry, then the children are not going to eat it.
Yeah.
So having too much ice cream in the freezer or cookies or wrong foods available, instead having fresh fruit available whenever they want to snack, and keeping freshly prepared meals. I know it's difficult in today's lifestyle, but that would be something to really encourage, and avoiding processed foods. GLP-1 RA agents are very important to keep the food noise down. They also help by controlling the cravings and certain habits. We tell them, it was mentioned that we should have dinner earlier. I tell people to brush their teeth after the 6:30 dinner, and that means they cannot have anything other than water. So some of these things are habits that we can encourage people to do and certain families to do, so that we can at least make sure that the next generation is going to learn from what we are seeing now. Because we do see very early cardiac disease in the 40s and 50s when people have multiple risk factors, including high, cholesterol and high blood pressure, obesity, sedentary lifestyle. So I think getting to the root of that and making that impact at basic grassroots level is extremely important, and that way yoga is very important too. I've been an American Diabetes Association chapter president here, and we go out to schools, Rotary Club, Lions Club, and talk about making these changes at the level of basic nutrition. And it works very well. I think level of education matters too, because educated people are definitely going to pay more attention than the hardworking people who don't have time to cook or buy, or they go through fast food centers and things like that. So I think awareness is number one, and then available policies will definitely be helpful.
What is encouraging is, we talked about metformin, GLP-1, etc. It's part of this conversation, but each of you as clinicians seeing patients every day, you're highlighting the importance of the lifestyle as well. So I think that it's very heartwarming to see that, to hear that. Thank you for those insights. So Dr. Jyoti, switching to you, what is one misconception that you would like to correct when it comes to diabetes prevention?
I mean, we already talked about all the whatever, the hidden risk factors earlier, all that. But also, I think a lot of people think like, like diabetes only comes from like eating too much sweets or eating too much carbs, or, oh, I'm not heavy, I'm not obese, I'm skinny, I do this, I do that. I don't think I'll get diabetes type of thing. I think those are some of the misconceptions, because again, diabetes is a complex condition, right? You could still have a genetic risk factor. You could be eating other foods that have hidden sugars in them, or like, processed foods. Same thing we talked about, all that chronic stress, they can all again lead to the same problem, right? So you have to be aware, like, okay, oh, so I may never get diabetes because I'm so skinny, or oh, I don't eat sugar, so I'll be fine, type things. So yeah, and then again, genetic tendency is always there, right? Genetically, if you have a family history, you could be at a higher risk. So so, and then all that, those are the main
Yeah,
things I can think of.
yeah.
Yeah.
Yeah, one thing I think Dr. Chokshi made this comment about educational levels and all that. I tend to be very data driven. And just like Srikant's story, I was diagnosed with insulin resistance, and then I, I got the CGM, the continuous glucose monitor, and it made such a big difference in understanding how I respond to different types of foods. And it helped me bring my HA1C down as well, right? Without having to require any kind of medication. So I think the technology has evolved to a degree that, I mean, continuous glucose monitor, like our parents didn't have that luxury, right? Now we
Yeah.
can be
There
far
is
more
a
data driven and fact based.
There is a
Yeah.
monitor which actually people can buy on their own. This is for like all the audience. I wanted to let you guys know. There is one called Stello, STELO.com. It's made
Okay.
by Dexcom
Yeah.
makers. And this is a self-pay. I mean, you don't need a doctor's prescription. You all can order it on their website. It's around $85 to $89. It's every 15 days you change
Got
the
it.
disc. I mean, people who are pre-diabetic, who have insulin resistance, who want to really start tracking their sugars, because I have some patients I've recommended, and they have made great changes in their life, in their diet, and they've lost weight, they're doing better because they know like what foods are triggering their sugar to go up.
Yeah.
So I think this Stello is a great opportunity. It's a continuous glucose monitor, and I mean, it's relatively inexpensive compared to some of the
Correct.
other
Correct.
CGMs.
Very,
Even
very, yeah.
I put it on actually for just to see, like, I wore it for 2-3 weeks. And I mean, it was like an eye opener, like what type of foods will increase your sugar, what happens.
Sure.
You'll be surprised. Yeah.
Sure. Great. Dr. Ashraf, coming to you. I know you talked about several early life interventions. I mean, not radically different from how we adults need to practice that. Anything else you want to add to that? Any other intervention that we haven't touched upon so far?
So I would say that's a great question. Unfortunately, there is no simple answer to it, but if I have to pick one, I will focus on early on nutrition from two aspects: maternal, because we talked about why mother's diabetes, uncontrolled blood sugars, all of that is going to increase baby's tendency to store more fat, become more insulin resistant. So if we can focus on maternal nutrition, if we can decrease maternal complications of diabetes and control blood sugars, also increase breastfeeding practices. So that is like investment in future, because we can decrease risk for insulin resistance. Then the second part of nutrition is first 1,000 days of life, conception to 2 years of life. What's going to happen is if the child is exposed to, think about it, like sugary drinks or unprocessed food, their taste preferences are already formed at a very young age. So in some, we are also promoting increased propensity for all these unhealthy foods. So we also need to make sure healthy lifestyle habits like active play, all of these are incorporated. There is access to unprocessed food, whole foods. But as Dr. Venkat Naran was saying, this is not just an individual level. Probably we cannot ask everybody to do that. It has to be like a public, easily accessible, policy-wise driven support. At some level, it's very difficult for people to access diabetes prevention program if we have like employer wellness program or dedicated time for parents and caregivers who have to work, and they have to have access. So we have all these excellent programs, but people need to have access for nutrition and lifestyle. So I would start with the first 1,000 days of life and with maternal nutrition first, and then make sure our policies are supporting towards that, if I have to pick one. Thank you.
Got it. Wonderful. Actually, we are starting to get some audience questions as well. So maybe I'll start blending them in here so that the conversation can continue organically. Dr. Ashraf, this is again for you. What should a future mother do to control glucose / weight loss before pregnancy? Before pregnancy, so it's
Right.
mother of interventions, right? So
That's a very good question. So in reality, we do need to make sure, in adolescence or when before planning pregnancy, weight control. Like if the mother is, if the future, right now adolescent and future young woman is before conception is at a healthy weight. If they have diabetes, it has to be controlled. Whether they have type 1 diabetes or type 2 diabetes, it has to be really well controlled. And if we really, this question is very interesting. If we are thinking about before conception, there is a chance they could even try the GLP-1 medications and all, because we don't know the safety of it during pregnancy. But before pregnancy, that could be a chance. And there are other weight loss medications also that can be taken into account to support. Medicines are an adjunct, and as everybody else has resonated here, lots of time weight by itself, it is somehow set in hypothalamus in the brain. So it's once you have gained a lot of weight, it's really not in your control. Even though we always say individual, as an individual, you need to lose weight. Our hypothalamus has a reset. So when you lose weight, you get hunger signals. You start gaining weight. So it is sometimes that in some patient populations, we still don't understand who requires that. They do, and as many others have talked about the food noise, that is really prevalent in some of these children or adults struggling with real body weight excess. So we do need to think about that, not only like lifestyle and diet as we always talk about, but also support them in their journey, because everyone is different. People respond to different weight loss medications very differently. So we do need to think about, there is no taboo, whatever it takes to help them healthy. No, but not everyone will need weight loss medication, but some may need it. So we do need to be very gentle and sympathetic in terms of supporting people in that aspect. That's what I
Wonderful.
would.
Thank you. Thank you for that insight. And maybe Dr. Narayan, I'll come to you now. There is another audience question here. You talked about two potential solutions. One is policy related, and the other one is biology of behavior, is the phrase that was captured here. Can you explain what you mean by biology of behavior?
Yeah, this is quite a complicated topic, and there's actually a neuroscientist at Stanford. His name is Robert Sapolsky. He's written a classic book recently called Behave.
Okay.
It's based on years of research. So his basic conclusion is a little scary, is that what we consider free will is probably something that doesn't exist. So a lot of our behaviors is pre-programmed. At the margins, we might be able to make certain changes, but whether we truly can make changes is a question that he raises. Okay, and it's at all levels. So that is why policy level interventions like nudges work. I mean, suppose a nudge would be, let's take out the availability of certain processed foods or highly refined carbohydrates from the grocery shelf, etc. That can work. Don't fill your refrigerator with ice cream, fill it with fruits and vegetables. Those kind of things will work. And the other thing about the biology of behavior is, for some reason, the body defends its weight. People that lose weight very quickly gain it back. Even those who go on to GLP-1, when you stop the drug, within a very short while, 2/3 of the weight comes back very quickly. And studies have shown that the hormones that regulate hunger and satiety, etc., ghrelin and leptin, even after you've lost weight, even after your weight is regained, some of the hormones don't change. That means the body is also fighting it. So there are all kinds of things going on. And we spoke about preference to various foods. Certain preferences maybe they are biologically determined. Maybe you can't overcome them once you're exposed to it. Why is it some people who, when they taste alcohol, are more likely to become, substance addicts, whereas others don't? So maybe there's a lot of differences at the biological level that we need to understand. But then, I would like to make one other point, which is about, I know you're going to ask me that question about the future of prevention that I would like to see. All of this that we have discussed is one size fits all. I mean, this is a Walmart approach to prevention, which we should pursue, which we should definitely pursue. But science is also beginning to show that this 90 to 95% of diabetes that we call type 2 diabetes is a garden variety. It's not one disease. It's multiple diseases, at least with several different attributes. At one extreme, on average, populations of South Asia tend to be insulin deficient, or they're not. There's an inability to secrete enough insulin, and some of our early studies are showing there might be problems in the islet cells of their pancreases. I mean, they might be less endowed. They might not be. There might be differences in function, etc. At the other extreme is the people who are insulin resistant, where they have the capacity to secrete insulin, but the body becomes resistant to the action of insulin. Unfortunately, most of the research has happened in populations that are insulin resistant, and that is why research in Indian populations is beginning to unravel the importance of also understanding the insulin deficient form of diabetes. And maybe their diagnosis, even at pre-diabetic levels, their diagnosis would be different. I mean, Alka will tell you that the tests that are commonly used in European populations may not be enough for South Asians. You may have to, modify them. Secondly, the therapy might be different. If somebody is low, yesterday there was a new drug, small trial showing that a drug can, actually increase insulin secretion, and can preserve it. There is a big movement in the area of insulin regeneration. Can we in the future do come up with stem cells to implant
Yeah.
islet cells under the muscle. So that would be the future we need to think of. But in the meanwhile, I say, implement the Walmart kind of diabetes prevention across the board, impose nudges, and we have to customize. I think your idea of CGM is correct. I mean, different people respond differently to different foods and to exercise. So each
Yeah.
person customizing it for themselves would also be important.
I think it's actually, I like that Walmart approach versus hyper personalized approach, right? I mean, there is something in between which is targeted towards certain phenotypes or certain demographics. So, what you're talking about is intervention being required at all levels. One of the fascinating facts, Venkat, keep me honest here, but I learned this through my engagement with your group is that South Asian population disproportionately contributes to the diabetes burden in the world, about 30% or so, whereas published academic research is less than 1% that studies this particular population. I think that's I was shocked when I heard that, right?
And I think you should be shocked. And I think because again, we'll tell you, it's not just the South Asian population. When you look at the
Yeah,
NIH dollars spent on Asian Americans, which is
yeah.
about 8 to 9% of the population, the amount of dollars spent is 0.2% or less than
Wow.
0.2%. So there is a
Wow.
huge disconnect. You know, the problem is we are not studying the disease in the populations that are most affected. And therefore, we come up with the potentially, I mean, there's a quote from Mark Twain. He says, never read your health book too carefully because you can die of reading the misprint. I think that's what we are doing.
Yeah.
We're really printing a loss. I mean, the number of times I hear, friends, colleagues, etc., say, you know what, I've never been very obese, but my fasting glucose is high. Why? And
Mhm.
they're asking, you don't ask the person to lose weight. And my friend Suchi Chandrasekharan, who is an obstetrician, she'll tell you that a lot of South Asian mothers, in the second trimester, their GDM test may be normal, but they are born with large babies. So something is happening in the first trimester. We are missing something, and there are studies showing that those women that develop large babies, towards etc., without even knowing their GDM, may have low insulin secretion during the first trimester. The
Mm.
pregnancy is a period of demand for insulin, but the body is unable to secrete it. So maybe one test we might have to start introducing in the future is C-peptides, to measure insulin secretion. But we're not ready yet. We need to standardize those tests, but I think
Yeah.
there's a lot of interesting questions. And I think if there's one message we'd like to finish with, is that you're absolutely correct. So the disease in South Asians, we contribute to 30% or 35% of the burden of diabetes, but we contribute to 1% of research in diabetes. That has to change. And I think as a community, we need to think about how to do that. And it's not going to happen unless the community signs large checks and lobbies your congressman.
Yeah, and really appreciate some of the work that's going on with you, and I think Dr. Kanaya in your group as well, right? Addressing
Yeah.
some of these broader populations from a policy perspective. Maybe that brings it to Venkat talked about the disparities, right? And you also touched upon how different demographics are impacted differently. What would be an urgent call to action, if you will, to say that how do we reduce these disparities?
Yeah. No, so I think a lot of people have already spoken about some of the lifestyle and structural barriers that exist and how hard it is to change your behavior because some behaviors are hardwired. And so I do think that we need to work on a policy point. And the one, if I had a magic wand, what I would want is the structural barrier to be changed is the availability, access, and affordability of healthy food across the world. And that is not an easy task because we currently subsidize things that are not healthy. So we need to work on the food systems by
Hmm.
food subsidies, produce prescriptions or coupons to our most vulnerable populations, food labeling, just taxation on unhealthier foods. We've seen this work with sugar-sweetened beverages. Many countries have tried this, and they've seen dramatic drops in consumption of sugar-sweetened beverages and short-term outcomes of improvements in health status. The tobacco model works, labeling and taxation on unhealthy, that's not even being done in India, right? So
Yeah.
tobacco is, but food labeling, food taxation of the most unhealthy foods, and start to push the lever so that it's more available. And that would help all populations at risk, no matter, where they live. And it's much easier to do on a population scale than on the targeted scale. It leaves a lot to the onus to the individual person. A couple things I want to add is, we've been conducting the masala study in the US for 15 years. A partner in masala, her name is Dr. Nami Kandula. She's at Northwestern. She's done 2 trials, behavioral intervention trials of South Asian women, men, and adolescents. Both of these trials were individualized behavior change, like lifestyle, promotion of physical activity, of healthy diet, food label reading, blah, 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 all the stuff that the DPP has done in South Asians. And she saw in very well done trials, no real effect on the outcomes in South Asians, culturally translating. And so that tells me individual level interventions do not work as well in South Asian populations as they do in other cultures. And so we have to kind of think about what levers would really move people. Is it going to be an intervention aimed at the one person in the family that is the most, important or most influential? So are there, people in the family unit we should be including in these interventions, or should we be doing larger interventions, societal level, like the food policy interventions?
Yeah, I think you brought up borrowing from the page of tobacco playbook, right? About taxation, etc. One of the things that I see now is sugar tax. Different countries, different governments are already adapting that as maybe put the burden a little bit on the consumer so that, they feel the pain. Uh, but what is also fascinating and a bit counterintuitive is the more processed the food is, the cheaper it seems to get. It's something to do with the industrial scale production, I guess, at which you mass produce the heavily processed food. But it's very counterintuitive, by training, I'm a supply chain professional. To me, every step you add in the process, it has to increase the cost, not decrease the cost. But it's quite counterintuitive. Speaking about food, maybe this should go to Vidyaji. Um, you know, how much food? One of the questions that came up is quantity of food per meal. How much should I take? What should be the frequency of the meal? I'm going to add in one more to that. Some of my friends practice intermittent fasting. Is that recommended? And for me personally, I have to keep eating something every half an hour. That's a different problem. But just curious about frequency of meals, quantity of meals. What's been your experience?
Again, this is very individual, everybody's body type and activities and schedule. Talking about intermittent fasting, I don't know if you know, but I have been practicing one day fasting, one day eating. So I do complete 36-hour fast every other day. And this is my 12th year doing this. So continuously I've been doing this. And most of the time people are surprised. Oh, how do you do that? Don't you get headaches? Don't you? Because every now and then we keep hearing this message. We need to keep eating every half an hour, every 2 hours. I feel that is the commercial food manufacturers that they get this message out to us that we need to keep snacking every time. We don't need to if you eat right amount of food. So it's not that's just the fasting, but it's really important what you eat when you eat. So, if we think, oh, we are all busy, we don't have time to cook. But that's one thing we do on daily basis to sustain our bodies. to sustain our life. And if we don't have time for that, then we need to reset our priorities. And it doesn't have to be very elaborate cooking every time. When you think about cooking, and I do cook my meals for my family from scratch, but it doesn't take my whole day. I teach 7 classes every day, actively standing there. So it's not that I have a lot of time on my hand to cook, but you have to simplify, and you have to have a system. Okay, every day I'm going to soak one bean, and I'm going to cook one vegetable. It's simple. It doesn't need to be very elaborate cooking, but just add simple whatever system you have. Okay, simple cumin, mustard, haldi, chalk, and saute that vegetable and cook one whole grain on the side. Maybe it could be brown rice, it could be barley, it could be buckwheat. Simple things. So it's nothing coming out of a polythene bag or nothing coming out. I don't have any ready-made cooked or ready-made boxed meals in my house. If you come to my house, it's all a pantry filled with all the whole grains. So those who are asking about food, I will suggest if you start eating whole grains, your body takes much longer to break down those foods. So you will not be hungry again in half an hour. Most of the times we get so hungry again and again because we are eating processed foods which get absorbed in the body really fast. So you need to start eating more complex carbs instead of low carbs. So instead of low carbs, go to slow carbs that your body takes longer to break down and digest. And that's really important to start for your children also, because if you start cooking different meals for children and different for adults in the family, then you are depriving your children from growing in a healthy way, and they are going for those easy choices. So at some point you have to be the parent in the house and say, okay, this is what we are all going to eat, not giving in to your children's my friend is eating this, this friend is eating that, can we have that in the house? If you know this is not good for you, just don't eat it and don't serve it to your guests. We think, oh, I don't eat this, but I serve this unhealthy meals, like or like some cookies, cold drinks, and sugary drinks to my parties. So that means we are making it a rewarding meal to give these unhealthy foods. We should be eating healthy and serving healthy in all our family in dinners, and even when we have guests over, or even when we are hosting big events. So again, it's definitely a mindset shift, changing the community behaviors, not giving into societal expectations. What is society? When I used to say that don't eat any bread, no matter what it says, 13 grain healthy bread, it's not good for you, it's not healthy, it's cooked manufactured commercially, they don't have any loyalty to you. Their loyalty is to their shareholders. So don't listen to these messages that these commercial food manufacturers are sending your way. Eat healthy and cook healthy at your family level, individual level, and that will start making that change at the societal level. Yeah, but yeah, we do have to watch. If you start eating when you are hungry and not eating habitually because everybody else is eating or because it's time to eat, that will also start cutting down on the amount that you're taking in. So diabetes and of course the sugar is directly related to the foods that we are consuming, the drinks that we are taking in. So you have to watch what you are eating and how you are preparing those meals, and doesn't need to be very complicated. That's what it is.
I think it comes down to planning your meal, right? Planning your grocery trip,
And
making
giving
sure
it
that
importance,
you
like giving it the importance that it deserves. That don't just brush it. Oh, I'm busy, I don't have time to cook. That means somebody else's responsibility is to give you the healthy food. No, start taking responsibility for your own meals.
Yeah, but I think you also touched on a very important point. Each of us are wired differently, each of us are made differently. There are certain principles that translate universally, but you have to understand your body and how you respond to different foods as well, I
Correct.
think is equally
Correct.
important. I see Kuldeep ji has his hand up, but here's what I would propose. If any of you have any closing thoughts, you can share, and then we can bring the formal part of the conversation to a close. And then if you can stay on, we can have a little bit more of an informal conversation with the attendees today. So anybody want any compelling thoughts that you're thinking, I haven't put this point forth, please feel free to right now.
So I will say we are a lot more in the mental space these days and very little in the physical space. So because of again all the digital media and everything, our
Yeah.
eyebrows are glued to the screen. So if we can start cutting down that mental space activity and come more into the physical space, that will be really beneficial for entire families.
Wonderful. Wonderful. Anyone else? Okay. So what I like to do is just take a couple of minutes to summarize a few takeaways, at least that I took away. I thought the conversation was fascinating. We had such a diverse points of view that, what I will do is I'll quickly summarize. First and foremost is sleep well. We talked about sedentary lifestyles and how they could potentially impact. Making sure that we maintain an active lifestyle is very important. And then Ashraf, you brought up the point that it needs to start pretty much at even prior to conception, right? All the way from there through the stages of growth, it needs to carry through. That's one other thing we talked about. And then Venkat, this three cohort study example is fascinating between the placebo and the metformin and then the lifestyle intervention, and lifestyle intervention as the one coming out ahead. Not surprising, but I think it's very good insight. Also about eating habits, not eating for the sake of comfort, not eating for the sake of eating, but eating just to make sure that we are able to sustain our body and have discipline around that, and planning that is something that was called out. The role of GLP-1s, I think we should be a bit more open-minded and not be too stigmatized with maybe taking a medication, taking a pill, etc. If that is the right intervention, that is the right intervention. And then we also talked about not every human is created equal. We talked about how differences and disparities exist between different populations. Most of the audience being of South Asian origin here, I think it's important to understand and associate ourselves with higher risks to some of these chronic diseases and take the responsibility upon us to make sure that we're able to uh, shape our own destiny to the extent possible. And last but not the least, I think the Stelo.com, the Dr. Jyoti, I think that advice is very concrete. As somebody who used CGM just to understand how I respond to different types of foods, 100% agree with you. I think there are so many aha moments when I consume certain type of food that I thought is healthy, and then the kind of sugar spike it results. It's very eye-opening. You have to be fact-based and data-driven. So once again, thank you so much for sharing your knowledge and your know-how. Really enjoyed the conversation. I'm sure the conversation will continue for a few more minutes, but what I like to do is invite Kusuma Buddhiraju to deliver the vote of thanks to our panelists. And Kusuma, just so that you know, by the way, she was commenting on the book as well, Venkat, that you brought up about Behave. I'm going to pick it up and read it as well. Kusuma is an economic policy and analytics leader with over a decade of experience, bridging rigorous data analysis with real world policy and institutional reform. She has been volunteering with Sewa USA for almost a year, and she's pursuing a master's in public administration from Columbia University. So, Kusumaji, please, take it away for vote of thanks, and then we can open it up for some informal conversation.
Thank you, Madhavji. Honestly, this has been very illuminating to me, listening to so many perspectives. And just to say, I mean, everyone has invaluable experience here. And we really thank you for your commitment to joining today's Policy Cafe on preventing type 2 diabetes. We are exceptionally grateful for all the practical insights and many things that all of you were mentioning kind of hits me because I have huge sugar cravings. So yeah. So and the lived experiences that all of you are sharing, and also about how the patients that you see. So we understand that this requires not just awareness but also sustained collaboration across policy, healthcare systems, and grassroots efforts. So we just wanted to mention that today's conversation is not just going to be a standalone event from Seva's side, but it'll be a part of a larger journey that we are trying to build together as a community. And so far, we have done previous policy cafes on education, non-profit management, disaster response, and hunger-related challenges in the United States. And through all of them, our hope is always to continuously learn, constantly reflect, and grow at every grow through every conversation. So in that endeavor, today actually adds a great in-depth important layer for us in bringing diverse voices to understand how researchers, policymakers, practitioners, and community leaders are tackling a critical health issue of our time. And Venkatji, I read the book Behave, and I also read the other book called Determined by the same author. And he is an exceptional, I think he explains everything so exceptionally, to be honest, about free will and the limits of free will. So, as we continue this journey through policy cafes at Sewa, we warmly actually invite you to please stay engaged with us. If you ever want to email us, join our upcoming policy sessions, we would really love to see you be a part of it. We have two upcoming policy cafes, one on education and one on senior Seva in the coming months, one in April and I think the other at the start of May. Please correct me if I'm wrong. And we hope to expand on the conversations that we have previously across different sectors. And we will also be sharing all, key takeaways and stories from today's discussions with a wider audience. So we might reach out, to you again, either for your quotes or to just get your approval on a few things so that we can amplify the impact of important ideas and solutions that emerged from our conversation today. So I think can we go to the QR code slide? Yes. So I would kindly request all of you to scan this QR code that is shared here to learn more about Seva's work on the Stop Diabetes movement and explore different ways to stay connected and contribute. And I'm assuming all of you have our emails, so we would be glad to connect with you at any point. If you think that Seva can be your partner in sharing information across different audiences. And because we're looking to build long-term partnerships with all of you and foster meaningful collaborations that can translate our dialogue into action. So, Madhavji, do you want to take it forward, sir?
Sure. No, I think you summarized it pretty well. What I like to do at this point is, Sukanyaji, if we can stop sharing the slides and bring everybody onto the screen. And those of you who are remaining online, you can turn on your cameras and maybe I'll have, if you want to raise your hand or something, we can just go and start some informal conversation. Kuldeep ji has his hand up. So Kuldeep ji, you want to start? You're on mute, by the way. No, I don't
Okay,
hear.
maybe. Am I there now?
Okay. Yeah,
Okay.
you're there. You're there now.
Okay. My question is about the oils. It was mentioned that we should use good oil for cooking and stuff like that. And I hear all kind of things: canola oil, avocado oil, ghee, coconut oil. I'm just wondering what is a good one to start using.
Okay, having said that, I can start. In general, the monosaturated oils are good for you. Olive oil is the extreme example, a classic example. The saturated fats are probably the most, in terms of health, they're the ones that cause the problems. But again, you can pick your choice. But one of the problems with even with monosaturated fat is the moment you heat it, some of its benefits go away. And if you heat it repeatedly after storing the oil overnight and keep frying it, you increase the amount of free radicals in it, which damages your endothelial, the endothelium of the arteries, and that's what predisposes you. So I think the right approach would be the right quantity of fat. You need fat in the body, but use the better quality fats, like the monosaturated or the polysaturated fats. Yeah. Alka, any
If I were
additions?
to ask you specifically, if I were to ask you, make a choice between canola, avocado, ghee, coconut, what would be your recommendation?
I'll tell you what I use
Okay.
at home. All our cooking has been changed to olive oil. We Mediterraneanized our cooking. So, and we use a lot of avocado. Those are the two oils that we use very commonly. We occasionally might add a small pinch of coconut, and for a prasad there might be a little ghee, which we don't deny it. But our 99% of the time it's olive oil and sometimes avocado.
Thank you.
But that's my choice.
Thanks.
I'm not advertising for
I
it.
think avocado oil has a high smoke point. I think it's used for the higher cooking, but I think it has a flavor to it. So
Yeah,
I heard that it
at
does,
least
and it's also expensive. It's also expensive. So I think.
I haven't used avocado oil. I use fresh avocado. I use it like butter.
Okay.
Yeah,
They
fresh
do sell
avocado.
avocado oil in Costco. It has a high smoke point. It can be used for frying, but it's pretty expensive and it has a flavor to it. So yeah, I think olive oil I heard is okay for like moderate. I mean, it has a lower smoke point, but I think you can like saute things in it. But I don't think you can do it for like frying like budgies and all that. For that, I think you still have to go to like sesame oil or something else.
Or you can air fry your budgies. That would be a better choice.
Yeah. Yeah. What about ghee? Because lately I've been hearing from Ayurvedic people that ghee is good. You guys should not go away from ghee. We should eat ghee. Compared to all these oils and stuff like that, is ghee a good choice? Not a good choice?
Ghee is a good choice for adding from the top. So if you're eating rice or roti, just apply it from the top. So don't fry anything in the ghee. Maybe a little bit small tadka here and there is good.